First of all, stricture classification. I think it's important that we realize that there are different kinds of stricture. You have the simple stricture, which is in most cases a peptic stricture, but can also be related to eosinophilic esophagitis, a Skatsky ring or an esophageal web. These are all simple strictures. They are in general short, less than 2 centimeters, straight, and most of the time they allow the passage of an endoscope. So these strictures are most often very easy to treat. In general, they need 3 to maximum of 5 dilation sessions. And these simple strictures, they count for about 75% of cases. However, there are also complex strictures, and this can be after endoscopic submucosal dissection or a complex EMR. Also anastomotic strictures in case of partial esophagectomy, for example. Caustic ingestion can cause a complex stricture, or they can be radiotherapy induced. And sometimes also the eosinophilic esophagitis can give a complex stricture. So what are the characteristics of these strictures? They tend to be long, more than 2 centimeters, angulated, and they most of the time do not allow the passage of an endoscope. So these strictures really have a higher tendency to become refractory, and we see them in about 25% of the cases. What is the definition of a refractory or recurrent esophageal stricture? So we use the Kochman definitions. I think they are generally accepted. So a refractory esophageal stricture is defined as a stricture in which you have the inability to maintain the stricture diameter to 14 millimeter over 5 sessions at 2-week intervals. So if you have, after 5 dilations with 2-week intervals, not reach a diameter of 14 millimeter, this is called a refractory esophageal stricture. A recurrent esophageal stricture is the inability to maintain a satisfactory luminal diameter for 4 weeks once this diameter of 40 millimeter has been achieved. So what can you do if you are in this scenario? Sometimes it's helpful to inject locally into the stricture steroids. You can typically this is done with intralesional injections in the 4 quadrants. We use triamcinolone, and so this is then followed by endoscopic dilation. There was one study that showed that in patients with recurrent peptic strictures, there is a significant benefit of this approach. No significant benefit was seen, for example, in anastomotic strictures. You have to realize that if you inject corticosteroids in the esophagus, and you do this often, that there will be an increased risk, of course, of Candida esophagitis, as is seen also with inhalation therapy, as you know. So what types of stent do we use in the esophagus to tackle this problem? So there were self-expandable plastic stents. So the only stent that was available, I think, in Belgium or maybe in Europe was the Polyflex stent from Boston. But I think that the production completely ceased, so we don't have them anymore. So these stents had a success rate of 30 to 40%. There was a high risk of stent migration. Some studies even reported a stent migration of 50%. And there were also adverse events in 20 to 25% of the patients. Fully covered self-expandable metal stents also have a similar success rate. They still have a high migration rate if you don't do anything to overcome this migration or to prevent this migration. It is seen in 25 to 35% of the patients. And you see adverse events also in 20 to 25%. And then you have also this biodegradable stents, like the Ella BD stents. So the benefit of this stent is, of course, that it dissolves spontaneously, so you don't have to go back into the patient and remove the stent. There is less migration risk, although it's still around 15%. And there are also some adverse events. And in some studies suggest that it might be that there is a potential higher risk of serious adverse events with this biodegradable stents. We don't have a lot of literature on this. When would you consider if this patient would have to come back like every week or every 2 weeks for 5, 6 times? Would you consider a stent here or not?
No. Actually, yeah, I just heard your talk, but I'm much less enthusiastic about stenting. I mean, I've done a lot of people, I've done a lot. I did several patients in whom I did a stenting, and while they have the stent in place, they're okay. So they feel fine, etc. But when you remove the stent for this kind of stenosis, I'm sure that in a couple of weeks after, they will develop a new stenosis.
Okay.
So I think that repeated dilation actually is better than stenting for these kind of benign stenosis.
And local corticosteroid injection doesn't make sense here? So if you would have a perforation in this case, what would be your approach?
Stenting at this moment, yes. Then if I would have, of course, if I could close it, I would close it then with clips. But in the majority of cases, most of the time, it's a long perforation that you have. If you have a perforation, then it's a partially covered stent.
Okay. So partially covered, and then
well, partially covered because you want to have it fixed to the upstream of the stenosis, and of course, because you want to close it as good as possible, that there is no leakage.
And then you would leave it in place for 6 weeks, or
6 weeks, 8 weeks.
Can say, well, as of my personal experience, so the colonic stenting is technically the most challenging procedure. It's or the most dangerous procedure, I would say, because you can easily have a false root with the wire, and so we do them not very often, but I think this is the most challenging stenting procedure that you can perform.